So I would like to welcome Professor Gemma Piella. I hope I pronounced it correctly. She is a full professor at the University of Pompeu, Fabra, and she will talk about complex phenotype stratification.
Okay, thank you for the presentation. In this talk, I'm going to explain how machine learning can help in the stratification of complex phenotypes. So let's first introduce some concepts, although in the previous talk, some of them have already been introduced. Many diseases are complex and multifactorial. And to be able to provide a more precise diagnosis and personalized treatment, we require a more holistic view of a patient. And for this, we need to integrate lots of heterogeneous data. To some extent, this is what already clinicians do. For example, to diagnose a cardiac disease, the medical doctor will make a medical examination, ask about your family history, measure your heart rate and blood pressure, and maybe recommend some additional laboratory and imaging tests. All this generates lots of diverse data that is very challenging to understand and interpret. And sorry. And even more when we have a lot of patients, and we need to put in comparison one with another. And this is something that in precision medicine we need. So precision medicine aims to understand and treat diseases by integrating multiple types of data and providing a patient-tailored diagnosis or treatment. In order to do that, we need first, as I said before, to integrate lots of data, but of many patients, to be able to see what are the patterns that reveal this data and be able to divide these patients into subsets or to stratify these patients into subsets that have a common biological basis of disease. And these are these subsets that I will refer as phenotypes or phenogroups. Over the last years, we have seen that advances in data integration and phenotyping are inherently linked to advances in better diagnosis and outcome prediction. And we have also seen that data-driven machine learning methods is a powerful tool to achieve this. But only if these tools are really integrated in the clinical decision pathway, these tools will succeed, because otherwise the doctors will not trust them and will not use them. So one way to do this, one approach, is to try to emulate what clinicians do. That is, the doctors take all the available data and then, based on their experience and clinical guidelines, they reach a diagnosis or a decision. And implicitly, what they are doing is they are comparing. They are comparing that particular patient with the normal or typical cases. So, in the remainder of this talk, I'm going to talk about a specific approach that mimics a little bit this clinical reasoning. So, an overview that I will go more in detail afterwards is that we took data, diverse data from many patients, okay? And we simplify all this data, we map it into a low-dimensional representation where patients are positioned according to their similarity. Okay? So in this graph, so every patient would correspond to a point, and patients that are similar are close to each other. In this output space, unusual patterns are naturally stand out, and we can more easily discriminate groups of patients. And besides, then when a new patient arrives, I can, based on the similarity of this patient with the known population, I can project it into this learned space, and then the diagnosis or clinical decision is supported by what happened with most similar patients. So that could be the idea. So here there are three things that I want to highlight. The first is that the learning is done in an unsupervised way. The second is the integration of information. And the third is the simplification to a low-dimensional latent space. So let's start with the first. Supervised deep learning is very powerful and can really reveal very complex patterns data, but it requires huge amounts of data, which in addition need to be labeled to be able to make proper predictions. Besides, deep learning often provides results which are difficult to explain. And this is okay for low-level tasks, such as image segmentation, but not so much for clinical decision, where you need interpretability. Okay? And besides, as I said before, diseases are usually complex, so just the typical classification into healthy and disease would not really reflect the complexity of the data. So because of all of this, we opt for an unsupervised learning, where therefore we are free of the constraints imposed by this labeling, which are often which are sometimes wrong or not precise enough, or just they are biased or not representative enough of the variability in the population. And it is instead dictated by patient similarity. Okay? Although this learning is done in an unsupervised way, we can enrich the interpretation incorporating previous knowledge a posteriori. So, for example, what I said before, we can, based on the similarity of what happened to similar patients, we can predict what will be the trajectory or what will happen with a particular patient. Okay. So the second thing that I wanted to talk is about the simplification into a latent low-dimensional space. This is known as dimensionality reduction. And one way, it's not the only, but one way to do it is manifold learning. So let me illustrate this with an example. Here you can see a database of images of an object. Each image is of size 64 by 64 pixels. Therefore, is a huge quantity of pixels, and we can consider this as a high dimensional. But not every picture of 64 by 64 pixels could belong to this data set. In fact, there are very few degrees of freedom in this data set. One image can be distinguished from one another by using the shot angle of the camera. So if the head is looking more towards the left or towards the right, or up and down. So instead of representing this image by 64 by 64 pixels, we can summarize by, for example, just using two parameters. No? Of course, it doesn't encode all the information, but it's a good summary. Well, this is what tries to do manifold learning. So manifold learning tries to uncover this latent, low-dimensional representation that allows a more efficient processing of the data while maintaining relevant information. As a toy example, manifold learning would take the Earth, which is a 3D sphere, and would unwrap it into a 2D map. Okay, so, and how we find this manifold? Let me first define what is a manifold and how we can characterize it. A manifold is just a topological space that locally looks Euclidean. In the previous example of the Earth, for us, the Earth is flat, no? Because we are very small in comparison with the Earth, and we are looking at it from a very, very local perspective, so the Earth is flat. That would be the manifold, no? A topological space that locally looks Euclidean. Now, if the manifold is smooth enough, its structure can be characterized by the eigenfunctions of the Laplace-Beltrami operator. This operator is just as a generalization of the Laplace operator on the manifolds. The eigenfunctions describe the structure of such manifold. And this can be seen as a generalization of the Fourier analysis. So eigenfunctions corresponding to small eigenvalues would describe the global structure of the manifold, while eigenfunctions corresponding to large eigenvalues could capture the details of the manifold. So for example, let's consider this surface. So a surface can be seen as a manifold. And here we can see how successive eigenfunction looks, no? And we see that it progressively oscillates more and more, no? So more on the left, there is the first non-constant eigenfunction, then 30, and to the right, the eigenfunction corresponding to 500. And similarly, if we try to reconstruct from the frequency coefficients, this manifold, we would obtain this with using only 18. And if we progressively use more and more, we would, every time we would be more faithful to the original surface. Okay, so summarizing. Manifolds are characterized by the eigenfunctions of the Laplace-Beltrami operator. But to compute these eigenfunctions, we need the manifold. And this is precisely what we don't have, what we are trying to discover. So what we can do? Okay, we don't have the manifold, but we have some data that we are assuming that it's on this manifold. So what we can do is to approximate the manifold by constructing a graph. In this graph, every vertex of this graph would be a sample of my data. So in the previous example, it would be one of these images of the face. And the edges that link these vertices encode the similarity between these samples. Okay. This graph is known as graph Laplacian, and under some mild conditions, it can be shown that is the discretization of the Laplace-Beltrami operator. So, finding the manifold boils down to first constructing a suitable graph, and then finding the eigenvectors. And by just taking some of these eigenvectors, we achieve this dimensionality reduction. Okay. Now, this finding these eigenvectors can be formulated as an optimization problem. In particular, for the graph Laplacian, this equation over there that I cannot point. So here, what we would do? From our population, we would compute the similarity, the pairwise similarity between any two samples of my data. This similarity could be learned, but typically it is obtained by a kernel function. So a kernel function is just a function, a mathematical function that has some nice properties and that measures the similarity between two individuals. For example, a typical choice is this one that I put here. It's the radial basis function with the Euclidean distance. Now, if two samples of my data, X, which is of dimension 64 by 64, so for more than 4,000 dimensions, if two of them have similar pose, we will have that this Wij, which is the similarity between individual I and individual j, will be high. And if Wij is high, then because of this minimization, we'll have that these, which are the representation of my individual in the output space, the minimization will enforce that this is small, so that this Yi, representation of individual I, is close to the representation of individual j. Okay? So by minimizing this, I can achieve a low-dimensional representation. Here, in particular, is just two coordinates instead of the 4096 of the original space. And the data is organized on the horizontal axis by the left-right pose, and in the vertical axis if the head is up or down. And this is just a constraint of the minimization to remove the scale factor and avoid trivial solutions. Okay, so so here, when we compute the similarity, what we do is to compare intensities. Okay? And although it's a high dimension, it's of the same time. All of them are pixels, are intensities. What happens when we want to combine different types of data? Well, we extend this to allow to combine different types of data by assigning a kernel to each of the input variables, or the descriptors. So now, for each of the patients, I will have a matrix. I will have a matrix which measures, this would be, that encodes the similarity of individual I with all the others individuals and for all the descriptors. Okay? And what I wanted to do, because at the end I wanted to combine these different descriptors, I'm going to combine them, in this case it's a weighted linear combination, with these weights that it's going to be assigned to each of the descriptors. So now, instead of, so now the position in the output space will be given by this equation, where this, I'm projecting, I'm combining with the beta, which is a vector, I'm combining the different multivariate similarities and then projecting to an output space. Okay? So this is now, instead of having the previous equation, now I have this equation where now there are two unknowns, which are the projection matrix A and the beta, and the weight combination. And this can be solved by an iterative two-step optimization. First, we fix the beta and solve for A, and this then the optimization reduced to a generalized eigenvalue problem. And then we fix A and solve for beta, because it's a quadratically constrained quadratic problem. We use semi-definite programming to solve this, no? And we do it iteratively till the convergence. Okay. So with this, what we have is that each of the inputs individuals is represented, no? So for example, in this picture, by just 3 coordinates. Every dot could correspond to a patient, and patients that are nearby each other is because they are similar in their input data. And now what we can do is just when a new patient arrives, I don't need to do again all the optimization, but I just have to project this new patient with the parameters that I have learned, the weights combination and the projection matrix, and based on the similarity of this new patient with all the others. And, well, this allows me to do several things. No, one of the things, because similar individuals are positioned close to each other, I can easily find clusters of similar patients, no? Phenotyping. So I can make phenotyping. Or, for example, one of the things we can do also is to see the variability of the input space, because we can move in any direction of the output space. We can move any direction, and we can map back to the input space by kernel regression. And in this way, I can see how the input features are varying. Okay? This is useful when I want to understand what is going on in each of the phenotypes, for example, and I want to identify abnormal patterns. And finally, also, if I have longitudinal data, what I can do is to project each time point as if it would be a sample of my data. No? And then by joining these time points, I have a trajectory, which can be useful for temporal follow-up or to decide an intervention. Now, we have applied this method as a starting point of several applications, and I'm now going to explain some of them. The first application is the stratification of patients with a cardiovascular disease and at risk of heart failure. We wanted to see if we could identify those patients that could benefit from the cardiac resynchronization therapy. This is a clinically proven therapy for individuals with risk of heart failure, but there are 30% of the patients that do not respond to this therapy. And it is expensive, time-consuming, and involves some risk. So there is an interest in being able to identify those who will respond. Okay? So here we work with a cohort from a clinical trial of more than 1,100 patients. And the patients were randomized to either cardiac resynchronization therapy with a defibrillator or to an implantable cardioverter defibrillator. And for each patient, we have echocardiographic data and the some clinical parameters. So from the echo, we extracted volume and deformation patterns, regional deformation patterns of the myocardium, and combine it also with other clinical parameters such as age, sex, and also timings from the electrocardiogram and other parameters. And the idea, as I said before, we are going to use this unsupervised multiple kernel learning to project it into an output space. So here in this, every dot could correspond to one of these patients. Now, because similar patients are close to each other, I can try to find phenotypes to do clustering, okay, supervised as well. And then after I do this, I am going to look at each of these phenotypes and trying to characterize it and to see how the treatment affects their progress or their evolution. Okay, so with this data set, we found 5 phenogroups that present that were clinically significantly different in the majority of their clinical characteristics. Okay. One of the phenogroups respond very well to the therapy, and we call them super responders. No? And here you can see the curves of the probability of the survival free of heart failure, and you can see how the red, which correspond to the cardio cross-synchronization therapy, have a higher probability of survival than not the ones that receive the other therapy. On the other hand, there was another phenogroup which seemed not to benefit from the therapy. Okay? So these were the non-respondents. And then there were the other 3 that present a slight improvement of the cardiac resynchronization therapy, but not as significant as these ones. Okay. And as I said, using kernel regression, we can move in any direction of this output space and reconstruct how the input features would be. So it's a kind of like in principal component analysis where you see the variability. So for example, here we reconstruct what would be the deformation curves if we move along the first dimension of the output space. Okay? So here each color corresponds to a region of the left ventricle. And what we can also, of course, is to do this in each of the phenotypes. In fact, for example, we can reconstruct virtual patients. So here we take the barycenter of each of the clusters, and this barycenter would be our representative of this phenogroup. And then reconstruct what would be the input features that this virtual patient would have. So, and here this is for each of the phenotypes, the deformation curves and the volume also curves. Okay, this is another example, hypertrophic cardiomyopathy, where it is also a disease with a very wide spectrum, which involves a lot of changes, both at structural and functional level. So distinguishing phenotypes is an ongoing challenge. So here, our population was composed of 91 patients of hypertrophic cardiomyopathy and 47 relatives. Okay, and again, as input to this algorithm were some velocity, Doppler velocity curves, and regional deformation of the left ventricle. And also some clinical variables, age, sex, heart rate, etc. And here you can see how the output space looks like using just two, in this case, just two coordinates. And although the learning is done in an unsupervised way, that is, it is blind to the disease, to the status, no? We could, the algorithm organize it by severity. So individuals that are more on the left were those that had the disease more severe, while individuals towards the right were the relatives. Okay, and yeah, for example, phenogroup 1 and 2 corresponded to individuals that has high prevalence of positive genotypes and also a high prevalence of positive family cases of sudden cardiac death and a lot of comorbidities. Okay? Whereas, for example, cluster 6 corresponded to younger relatives with mild phenotypes. And again, here you can see some of the reconstructions of the inputs for each of the phenotypes. So again, we took the very center of each of the clusters and reconstruct the velocity profiles and the deformation curves. Okay, this is the last cardiac application, and it was about, we study left ventricular remodeling in relation with death or heart transplant in children with dilated cardiomyopathy. Here the cohort was composed of 47 kids with the disease and 25 healthy countries, also kids. And we use, once again, the deformation curves of the echo data, together with Doppler velocities and clinical parameters, in this case, age and body surface area. And again, we found this output space, and in this output space, we make the unsupervised clustering and use other information, such as the clinical outcome of these patients or other information to characterize the phenotypes. So what we found is, here you can see in the output space, in this case represented by 3 coordinates, and we found 5 clinically different clusters. And in each of these clusters, we have different proportion of death or heart transplant. And, well, in particular, all healthy individuals were in either cluster 1 or 2, and all disease individuals were in 3, 4, and 5, except for this one, which was in cluster 2. Okay? And here you can see when we, some of the clinical characteristics for each of these phenotypes, for each of these clusters. Okay, for example, cluster 5 corresponds to the oldest, patients, the ones that were more medicated and with a high with combined systolic and diastolic heart failure, and with with a high prevalence of death or of heart transplant. And here, again, the reconstruction of the input features for each of the phenotypes, for each of the virtual patients that situated at the very center of the clusters. Okay. This is another application which is about developing a platform for labor monitoring. And the motivation is that, well, the death rate of mothers and fetal and neonatal deaths is still unacceptably high. There are a lot, and there is not a consensus of, especially of course, in developing countries, no, in low-income countries, and there is still not a consensus on what are the best practices or the best decisions in some situations, no? During the pregnancy and the childbirth. Now, there are many inequalities, both between countries and within countries. For example, no, in some countries, the percentage, no, of women that deliver by cesarean is very high. Even when there is no need to deliver by cesarean, some cesareans will be performed. Whereas in other countries, mothers that would need, because of the medical conditions, a cesarean, they cannot get it. No? The closest to a kind of decision support tool for labor is the World Health Organization Partograph. This is just a piece of paper where the healthcare provider plots the evolution of several fetal and mother measurements, no? During the course of the pregnancy and during the childbirth. And it is compared with some ranges of normality. But it has been shown that sometimes it does not generalize well, because normality, it depends on the characteristics of the mother. Okay? So that was precisely this project. It was about trying to have a personalized approach for an effective labor monitoring. And for this, we had a huge data set, almost 10,000 deliveries from Nigeria and Uganda. And for each mother, we have more than 100 features, and some of these features were also longitudinal. So we have them at several time points. So with this data set, we use 80% to do the learning of the output space. So with 80% of the mothers, we use the unsupervised multiple kernel learning projected into the output space. Okay? And then with the other 20% remaining, we would project the mothers into the output space based on the similarity of these mothers with the other 80%, and try to predict what will be the trajectory of this mother, and also if this mother would have an intervention, a cesarean or a bad outcome or other things. Okay. So here, what you can see in these graphs is the output space of the algorithm that I have explained before at admission time. So the first time the mothers come to the hospital, if I only use the data from this first time, I would obtain this output space. In fact, these 5 are the same, are exactly the same graph, only that is colored by different clinical variables. Okay? And what we see is that in this, so it's representing the first dimension of the output space and the second dimension. And we can see that this first dimension correlates with labor stage, with women on the left corresponding to women that at admission time were at earlier stages of the labor, and women to the right corresponding to those that were at later stages, because not all mothers when at admission time are at the same time point of the pregnancy. Okay, and well, yeah, we can see this because, for example, here it's colored by cervical dilation, and this one by contraction duration. Here. And we can see how the cervical dilation increases towards the right, and the contraction duration also increases towards the right. And the time between contractions, on the other hand, decreases towards the right. Okay? Interestingly, the position in the output space is not only dictated by labor variables, but also we can see in the second dimension that we can distinguish the country. Okay? So here the purple are from Uganda, mothers from Uganda, and the black are from Nigeria. And what is even more interesting is that this correlates also, there is also a correlation in cervix consistency. The cervix consistency is something that is done qualitatively. So this suggests that there might be some bias between the country and the way of assessing the cervix consistency. And now we have also, for example, in this graph over here, which is another dimension, we can see that it correlates with emotional distress. Okay? So, okay, so as I said, in these graphs, every point is a mother at admission time, the first time they come to the hospital. So it is expected that if we use also the follow-ups of these mothers, what they will do is they will move towards the right. And here in this plot, you can see some examples. Just for some mothers, we have joined the different time points. Okay, so every triangle corresponds to a time point, and we see that the more green triangles correspond to the admission time, the first time they come to the hospital, and towards more the yellow ones is at the delivery time. So we can see how the mother travels towards the right. And we can use these trajectories to try to predict what will be the trajectory of a mother. We project when a new mother arrives, we can project her data onto this output space and predict how will be her trajectory. Besides, this prediction can be updated with every follow-up. And we can also try to predict specific events. For example, here we predict if a mother would have a cesarean. Okay, on the top, using our approach, and on the bottom, using the partograph. Now, we did the prediction locally, and for that, just for simplicity, we divide the output space in 9 regions, and for each region, we did the prediction, both for the cross-validation set and for the testing set. We try to predict if this model could have a cesarean. And here you can see the performances. There are a lot of them, area under the curve, negative predictor value, etc. But just looking at the colors, you can also get a sense of how the prediction works, because it is colored using the minimum of the sensitivity and the specificity of the model prediction, okay? With pinky values corresponding to the worst color, to the worst performance, and orange and yellow corresponding to better performance. So the first thing that we can see is that, our approach is better than just doing the prediction of the partograph, because you see as the partograph has many regions that are pink, so that they have a lower sensitivity or specificity. And also another thing that we see is that there is a gradient towards the right, which, so being better predictions towards the right and not towards the left. And this suggests that it's easier to predict a cesarean and to predict it correctly when the mother is at more advanced stage of the labor, which is kind of logical. Okay. So this is just an example. And to conclude, I think that one of the important messages is that machine learning can have an impact not only in data acquisition and feature extraction, that is something that for a lot of years have already been seen, but also in clinical interpretation and decision support. By integrating different types of data, comparing it to known population, and leveraging all this information to try to predict outcomes or specific interventions. I explain a particular method that we have applied in our research group, but of course it's not the only one. There are many others. So, and that's all. I will be happy to answer any questions.
Thank you very much, Professor. Very insightful presentation. It was really nice to see what kind of patterns emerge from the data. And I guess that was the point of seeing how you can analyze data in different ways. So, any questions from the audience?
Interesting presentation. I have a question. You basically show that using this data analysis, you can predict more clearly outcomes of clinical situations. Now, do you have cases where this is actually used in a clinic to take decisions, and that the doctor really listens to you and decides to change his decision based on your data compared to what intuitively he or she would evaluate based on his clinical experience?
Okay, we are on the process of it. For example, with the World Health Organization, we also work with clinicians from Iran, and we are building a system which tries to recommend what the projections. However, I should say that still, still the performance are moderate.
Moderate. Now, if you use data, you have now used data from Uganda and from Nigeria. Can you transpose them to Milano like this?
Well, probably not really, because we see that they, here, for example, no, I was saying how you can differentiate the countries, because every, apart from maybe the ethnia, no, of the mothers that could influence on their characteristics, also the clinical practice is different. We have to take into account that this, for example, we have recorded when a cesarean would be done and so on. But of course, implicitly, this data set is biased by the country, because every country has a way of doing it, no? And we can see it, for example, in the cervix consistency, no? That correlates with the country. So it's true that this data also inherits the bias of clinical practice.
Okay. Now, you want to apply it to clinical practice. There are two hurdles. One is the reliability of your model. That's one thing. And the other thing is, I imagine, the cultural issue of a doctor relying blindly on a mathematician telling him that this and that should be done like this and like that, while he's used to think in terms of clinical intuition. Now, what aspect of it is the biggest hurdle to take in order to get this to application?
Yes. That's why at the beginning of the talk, I was talking about a little bit that it should be integrated in the clinical pathway. Because this approach positions, no, the individuals in relation to each other, we think that it's more close to their clinical practice. It's not something that tells you, oh, this is healthy, or this is disease, or this is phenotypes, and that's all. But allows you to understand why it's saying this, no? And its positioning it says, okay, this individual is similar to this one. Of course, the clinical interpretation should be the doctor, and the last word is always from the clinician. But we are convinced that these are tools that might help the doctors.
Okay, thank you.
Thank you for the talk. I wanted to ask you a little bit of a technical questions, because I saw in the slides that it may happen and the clusters appear to be like really close to each other. In that case, which is the discriminating factor that may choose a representative that is different from?
Yeah. Depends on the algorithm you use for clustering. So once we have the patients in the output space, we can use many algorithms to cluster them. Which is the right one? Well, it depends on the data, no? But there are, for example, the typical, very basic, but that my work is K-means.
Okay.
You apply K-means with all in this output space, and you obtain your clusters. Also, another thing I didn't mention, but is which is the number of clusters, because this is also something that you do not know.
Yeah.
And again, there are some heuristics that try to tell you about which is the optimal number of clusters. For example, the silhouette method, or there is one based on the eigenmodes. So,
okay, thank you.
So my question. Thank you, Gemma. Thank you very much. I would like to come back to Jacques' question and one of your answers, where you were actually highlighting that you can maintain a relationship between the different space, large data space, and then the reduced data space that explain specific clustering. We're very focused always on clinical recommendation and decision support systems, etc. But I see a very great potential, for example, in using this kind of models to define policies. So it can be policies at different levels, can be policies at hospital level, policies at the regional level. So having clearer criteria that would actually not force but motivate a specific kind of either exploration or intervention to rationalize a bit better the medical resources. So could you comment on that? Is that something that came across your research?
Yes, in fact, with, I don't know if it's here, Pablo? No, it's not here. One of the things that we commented, but we have not yet done it, is precisely about this, about recommendations. Yes, yes, yes.
Can I ask the last question then? Because I've seen sometimes when they do biomarker discovery in the principal components, you have a lot of proteomic data, and then you get, for example, every patient, and then you do clustering. And from there, what you do is that you look at the principal components and the eigenvalues and say, oh, this patient has a lot of IL-6. That's a biomarker, for example, for a condition or whatever. So do you think it could be combined with your data, have clinical data, proteomic data, transcriptomic data, cluster them all together and see what kind of molecules could actually help in the stratification of doing more personalized medicine, but down to the molecule?
Yes. In fact, we are now using it for with metabolomics and proteomics in a study to study the endothelial dysfunction. And is the same now, but the different metabolites. Yes.
Yeah, I think. Any more questions? No. Oh.
Fast.
I was actually a bit hesitating to ask the question. I don't want to make any of the people in the clinical field angry, but do you think after that, like after, especially after the answer that you gave, we will be able to like omit the clinical point of view or like the intuition from the equation and base it all on like numbers, facts, and all of these data that we have here? Like, because as I understood that you based this model based on the recommendations of clinicians.
You mean to replace clinicians?
Yes.
Well, no, the answer would be no.
Like as...
No, these are tools that will help them to work better, but no. Okay. I mean, it's like all the technology, no, that help you to do your work better. But of course, their experience is.
Of course. Yeah. Thanks.
Thank you very much.